As Dr. Sergio said before, I have a new point of view to treat the proximal humeral fracture. So my intention here is to present a new point of view, how I read this kind of fractures in the proximal humerus fractures. In other words, I would like to show you what happens with these kind of fractures, how I see the different fractures in the proximal humeral. Well, I would like to answer these questions after the presentation. What happens with the different types of fractures, and what is the most important difference between them? And finally, what makes the treatment difficult? Because we can see some fractures that goes well and some of them that goes very bad, is very difficult to treat. Well, first of all, I would like to remember the NIR classification. Sorry, it's written in Portuguese, but I think all of us know this classification that consider 2, 3, and 4 parts. Okay, if I ask you to classify these fractures, I think there is not a big difficulty to understand that those fractures you can classify in 2 or 3 parts. Okay, it's not difficult. But if I ask you to classify this kind of fractures, it seems a little bit more difficult. In the upper part of the video, in the left, how many parts, how many fragments can you find in this fracture? Or in the next one, it's difficult to classify. This is a classify that if you use just the X-ray, it seems very difficult. So then there are some authors that want to do a new classification to understand better what happens with these fractures. Like Dr. Ralph Hertel, he used the logo classification, and then later Dr. Herbert Hash tried to make another classification, but in my opinion, this is one of the most difficult classification to understand. This tell me that the surgeons are not satisfied with those classifications because we cannot understand very well what happened with these fractures. So I ask again, what happens with, what is the difference between those fractures? And what makes these fractures different? What is important in this kind of fractures? And why one treatment is more difficult than others? So I would like to tell you this kind of fractures we have. I think you agree with me. There are fractures in 2 parts, 3, and 4 parts. I think everybody agree with me. Okay. So what we can see the difference between those fractures. I propose to change the position. If you change the 4-part fracture in the upper part of the left side to the 2-part in the lower part of this slide, you change the position and you can see my proposed in the right side. Okay, so we have this situation, okay? And what is the difference between those fractures, in my point of view, that I think is very, very important? That the fracture in the upper part are not impacted fracture, and the fractures in the lower are impacted fractures. This makes the difference between those fractures. This is my point of view. This I would like to transmit to you, to to you. You have to pay attention in these kind of fractures. This makes the difference when you will treat this kind of fractures. So it's like this. What is similar in those fractures? There is no compression between the fragments. They are not impacted. There is no bone loss in the metaphysis area of the humerus. And what is the difference between the first fractures and now is in this kind of fracture, you have compression in the bone, in the metaphysis bone, and they are impacted fractures. You have bone loss. This is the most important point in my presentation, I think. So I propose to understand the fractures. Instead, you can see if they are 2, 3, or 4 parts, but you have to recognize that the fractures, if they are impacted or not impacted fractures. You see this kind of fractures. In the left side, they are not impacted, and in the right side, they are impacted fractures. Almost all 2-part fractures are not impacted, and almost all 4-part fractures are impacted fractures. So can we begin to understand this question? What happens with the different types of fractures? The difference is if you have impaction, if you have bone loss or not. What is the most important difference? Is that the most important difference between the fractures are one fracture, there is no bone loss, and another one, you have bone loss in the impacted fractures. This makes treatment difficult because when you reduce, when you put the fragments in the anatomical position, there is no bone loss in the metaphysis area, and this makes difficult the treatment. Maybe you will understand better when I show the clinical cases. It's not for discussion now, but just to clarify, to think better what happens. So when you don't have compression between the fragments, you can assemble the fragments and you can fix with a plate, with wire, doesn't matter. These kind of fractures are easier to treat. This is my point. So it's like any kind of fracture in the femur, in the tibia, anywhere. If you recognize, if you can see all fragments, you put all together in the anatomical position, you assemble them and fix with plates. Like in this case, you reduce and fix with this plate. Is a modification, is a kind of plate that I did, and I can show later if somebody has some doubts about this plate. But it's a nice plate. We can find a very good fixation. And this is another one case. You can see the fragments, you recognize all fragments, you put in the anatomical position and you fix. But when you have a compression in the metaphysis area, you lose bone, as you see in this picture. If you can compare with the near classification, I could say there is a 5th fragment, not 2, 3, 4 part, and 5 part also, because the metaphysis bone is disappeared. It's a virtual fragment. So you have to know that. You have to consider to treat this kind of fractures. This makes it difficult to treat this kind of fractures. As you can see in this design, you have a compression in the metaphysis, and then when you reduce, you have a gap that needs to be filled with bone graft, with cement, wherever, or one plate like you are seeing here. That is my proposal. Well, If you consider these kind of fractures, these impacted fractures, also I use to divide in 3 types. I call lateral because I consider the shaft in relation to the humeral head, because depending of the rotation, you can find some, you can see a change from a lateral, from a varus to a valgus fracture. So I prefer to say the shaft is lateral, considering the humeral head, or the central, that is the ice cream fracture, as described by here, and the medial one, that is, in my opinion, the worst fracture to treat, because it's the most difficult to reduce, as I will show later. So in this clinical case, you can see a compression in the second picture in the upper part. You can see a compression of this kind of fracture. When you reduce this fragment, you need to fill with a plate, with a bone graft, or whatever. So if you don't do that, you can have a cutout of the screws. You can have varus, deform it in post-operatory. Like this one, this is ice cream fracture. You reduce and you fill the defect, the gap between the humeral head and the shaft with this kind of plate. Or you can use bone graft, doesn't matter. But I use this plate that makes much more easy the treatment of those fractures. So my propose for you to understand that you need to consider that you can find impacted fractures and non-impacted fractures. Okay, like this, those not impacted fracture that you can reduce, assemble all fragments, and the impacted fracture that you lose fragments. As you can see here, one more. And that is my point. That is my propose in this presentation. I would like you to take home that you need to pay attention in the compression fracture, in the impacted fracture, when you have bone loss, and in the fractures that you don't have compression between the fragments. You can assemble all fragments. So, in my opinion, doesn't matter if you have a 2, 3, or 4 part fracture. The problem is when you find compression between the fragments, this makes the fractures difficult. This is the point. Okay, I would like to show you this. This is my point of view. If if somebody wants to search some papers, I wrote this paper doing a comparison between those 2 plates for non-impacted fractures, and I present also some case, my follow-up in the E4 Congress in Copenhagen, in Denmark, in 2011. And then I made this paper in a newspaper in Brazil from my hospital, Albert Einstein. And also I published this kind of paper showing the difference between those fractures as I showed before. I thank you very much. That is my point of view. I would like to pass you, and I hope you can understand.